Hello and welcome to your online lecture for traumatic brain injury. We just finished up a segment on mild traumatic brain injury. Now we're talking about catastrophic, life-threatening, life-ending pathologies. I'm Dr. Cosby, excited to be doing this lecture with you all. Our first stop is really going to be in the area of blood flow first. Understanding how blood flows to the brain is going to be extremely important. So for us to kind of summarize this, we could say that blood flow to the brain is really provided by two arteries. The first one is going to be the vertebral artery, which is going to be the most medial artery of the two. And then the second one is going to be the common carotid. Sorry about that. The second one's going to be the common carotid. So right here, that common carotid, most often we're going to palpate that as it converges into that internal carotid artery here. So we have the common carotid distally. As it moves into the neck, it becomes the internal, converges into the internal carotid and external carotid arteries. So again, common carotid here distally. As it progresses into the neck, it converges into the internal carotid and the external carotid artery. And so it's kind of counterintuitive, right? That internal carotid starts laterally, but then you can see as it progresses proximally, it will end medially, making it the internal. And then you have your external carotid artery, which certainly begins more medially, but then progresses and then proximally becomes a more lateral structure. So that's why it's called the external carotid artery. Two of those arteries, the vertebral artery and the internal carotid artery. So let me trace those. The vertebral artery here, and then the internal carotid artery, those two kind of converge together to form the circulatory network known as the circle of Willis, right? And so this is the circle of Willis. And what's the importance of the circle of Willis? What do you all think? Great. If you looked at this image and you said it really allows for proper blood flow from the arteries to both the front and the back of the brain, you'd be correct. The other thing about the arteries that kind of branch off of the circle of Willis is their major role is to supply most of the blood to the brain, right? So we can see we have this kind of left middle cerebral artery, right? We probably have a right medial cerebral artery, but each of these arteries will branch off of that circle of Willis in some way, shape, or form and supply different components of the brain. So if there's compromise to the circle of Willis, then we have diminished blood flow, which will compromise the patient, right, and may cause, let's say, a stroke, for example. So the circle of Willis is extremely important because it takes multiple nerves, it converges them, right, and then off of the circle of Willis branches some of the most important nerves, which are responsible for supplying blood supply to the anterior and posterior and lateral sides of the brain. So I'll bring this back out. And then I want to talk about the different types of hemorrhage that can actually occur in the brain, understanding, obviously, the meningeal layers of the skull, right? So we have, let's just go layer by layer. The first layer is the scalp. You can see that there. The next layer is going to be the actual skull itself. The most superficial layer, the layer that makes contact with the skull, is going to be that kind of periosteal layer of the dura mater. And we have the meningeal layer of the dura mater, right? And then just underneath that or deep to that, we can see it beautifully depicted here. We have the arachnoid or spider-like layer, right? And then last but definitely not least, we have the pia mater, which is going to hug the actual brain itself. So as we start thinking about different types of hemorrhages to the brain, we kind of have to allow our body to kind of think through things in that manner and in that way, right? So the first pathology that we'll talk about, our first type of brain hemorrhage we'll talk about, is an epidural hematoma, right? Epi, does anyone know what that stands for? Epi, like when we're thinking epi, what are we thinking? So it's above something, right? So typically with an epidural hematoma, the bleeding is going to be in the space between the dura mater, which we can see here, and the skull. So we have bleeding that occurs within or between the skull itself and the dura mater, right? And we can see that depicted really relatively well in this image. The next type of brain hemorrhage that we might encounter in the clinical setting is going to be a subdural hematoma. Sub meaning what? It means below, right? So essentially what we have is bleeding between the dura mater, as we can see it there, and which layer is that? The arachnoid, right? So we can see that there. So if we're being very specific about which dura mater layer, it's going to be the meningeal layer, right? That second layer of the dura mater. So we have subdural and epidural hematomas, and we have to be very careful with those because they involve different anatomical structures, right? This one is going to be further away from the brain itself. This is going to progress and be closer towards the brain and might cause more cognitive signs and symptoms. Both are very life-threatening in nature. The next type of bleed that we have is a subarachnoid. So as the name implies, what is it going to be below? So what is it going to live below? Great, right? It's either going to live below the subarachnoid layer or in the subarachnoid layer, but a subarachnoid hemorrhage is exactly that. It's bleeding under the arachnoid, but still above the pia mater, right? And this type of bleed is most commonly seen in patients who've had some type of aneurysm or can also result from trauma. The last type of bleed we're going to talk about is an intracerebral bleed, and you can see that there. So remember we said the cerebrum, which is a large portion of the brain, right? We've said that before. So think you're actually going to have damage or bleeding within an actual lobe within the cerebrum, right? And that can be pretty catastrophic. Most often this occurs from Coop or contra Coop pathologies most often, and it also can be in combination with a subdural and an epidural hematoma. In other words, the force was great enough to cause an epidural hematoma and also some type of cerebral hemorrhage. So we can see the four different types of we'll call them brain bleeds. There certainly are other concerns that we'll talk through as it relates to like really acute traumatic injuries, but those are the four common types that you will see in the clinical setting. So I'm going to zoom out here and then progress us forward to our first pathology, which we're going to talk about, which is an intracranial hemorrhage, right? So intracranial means inside of the cranium. So if we were to go back here and look at this image really quick, anything that kind of happens below that bony landmark, right? And so it could be epidural, it could be subarachnoid, it could be subdural or intracerebral, right? So let's talk about the signs and symptoms. Your patient's going to report a massive amount of headaches. They might be vomiting depending on how much blood is in the actual area. Oftentimes we see patients who have anoscoria, so unequal pupil sizes, right? That's always associated with a traumatic brain injury. Disorientation, altered levels of consciousness. And the big key things, which are differentials between a mild traumatic brain injury and a traumatic brain injury, we start to see an increase in blood pressure and typically a drop in the actual pulse. And this is an attempt for the body to kind of increase blood flow to the brain where it's actually compromised. So we see compensations occurring with patients who have intracranial hemorrhages over time. One of the concerns, and I've talked about this in the mild traumatic brain injury segment, is that we have a patient that we returned to play too soon following a mild traumatic brain injury, right? And so because we didn't allow for the recovery of the energy crisis or the restoration of the sodium potassium pump, right? And because the brain is lacking ATP, we return them too soon and they suffer from repeated trauma, right? And so when we see this happening, one of the things that we see in a more traumatic brain injury is that the repeated blows cause a disruption of the brain's ability to kind of auto-regulate, right? And so we see this massive increase in blood flow. We have rapid swelling that occurs within the brain. We have an increase in intracranial pressure that could be subdural, epidural, intracranial. And so we start to see herniation of the brain, severe edema. Because we have pressure on the brain, now we have a lack of blood flow to that area because blood can't get there. And so we start to see cellular death actually occurring, right? And this is terrible because the reality is in this particular case scenario, we could have prevented it, right? By allowing that patient to actually rest. So when we see a patient who has signs and symptoms of a mild traumatic brain injury, from a minor blow, and then they take another blow during practice and they rapidly decline, we're concerned. Our first thing that we're going to do is assess their blood pressure. If the blood pressure is up and there's a decline in their pulse rate, we're concerned. This is medical emergency. We're calling 911, right? The research suggests it's about a 50% survival rate. And it's going to be more common in athletes under the age of 20. Why? Someone tell me why. From the mild traumatic brain injury. Right. Their brain is immature. It hasn't finished growing. Therefore, it's not capable of auto-regulating and fighting the way that an adult brain would, right? Most often, this is going to require immediate surgical care. Usually they go in, they'll do some type of intracranial drill, they'll relieve the pressure on the brain, and hopefully the patient survives, right? That's the biggest thing. Hopefully the patient does survive this scenario. So I'm going to move to the next slide where we'll be talking about epidural and subdural hematomas. I've already defined them on the previous slide. Remember, epi above the dura mater, but between the skull, sub below the dura mater, and in between the arachnoid layer. So we get subdural, right? And we get epidural. One of the things that I want to draw your attention to here is oftentimes what we see is, even though an epidural sits a little bit higher up above the brain, both of these can be very catastrophic. So let's take a look here. An epidural hematoma, as the name implies, let's say you have a skull fracture, right? So as a result of the skull fracture, blood from mainly your rich scalp, right? Blood-rich scalp is going to kind of leak into the layer between the skull and the actual dural layer, right? Now, we can see what happens. Remember that periosteal portion of the dura is usually stuck or adheres to the scalp, right? Or to the skull. So we can see that not only do we have blood in between the two layers, we can see the dura mater has been pulled away from its skull attachment, right? Epidural hematomas are arterial in nature. And that's going to be key in just a few moments as we talk through the different pathologies. But I wanted to say that out loud first. Your subdural hematoma, you can see that the dura mater, for the most part, is still attached to the skull. So we don't have the peeling away from the skull. But we see that most of the bleed is actually occurring, probably coming from the cerebrum, right? So we have this venous blood sitting in the cavity between the dura and the arachnoid, right? And this is a venous bleed. And so as we progress, let's talk through epidural first. Epidural, as I mentioned, is an arterial bleed between the skull and the dura mater, right? Most often, 80% of the cases involves meningeal arteries. So as we look at this image here, and we're looking at the medial meningeal artery, which we can see here, you have the posterior meningeal arteries as well, which you can kind of see there. So we have lots of these meningeal arteries, which are kind of the culprit when we think about an epidural hematoma. So we have this trauma that occurs to the brain, right? That trauma maybe causes some type of stretching or compression on those meningeal arteries. And so what we start to see is those meningeal arteries, which live really close to the skull. Can you see that? Those meningeal arteries then start to bleed into the epidural space, right? The space between the skull and the dura. The scary thing about epidural hematoma is it's a rapid onset, and that makes sense. Remember I said artery. Arteries bleed fast, right? We can feel their pulse and the pressure. And so most of the time they're going to be symptomatic within 48 hours. The scary part about this is typically that patient's going to report signs and symptoms of a concussion or a mild traumatic brain injury, and you'll send them home. One of the reasons we say check the patient every hour during the first 24 hours is for this reason right here, the epidural hematoma. Oftentimes, the symptoms will progress. So they'll be lucid, then they'll be disoriented, then they'll have an increasing headache. They'll start to have some type of cranial nerve disruption, coma, and then death, right? So it becomes important for these particular patients to make sure we're waking them up every hour after the initial mild traumatic brain injury. After that first 24 to 48 hours, we're kind of clear. In other words, if they haven't presented with signs and symptoms of an epidural hematoma, at that time, we can rest assured, right? Now, your patient may complain of something called a thunderclap headache. What does that sound like to you? Exactly what the name implies, right? It literally lives up to its name. A strikingly sudden, like, clap of thunder, like it comes on so suddenly. Like they didn't have a headache 2 minutes ago, and now they have this crazy headache that is disrupting and is associated with a lot of pain. Now, the opposite end of the spectrum is a subdural hematoma, right? The beautiful thing about subdural hematomas is that they're a venous bleed, which means the bleed is going to be a lot slower. Most often they occur after some type of contracoup mechanism. The scary thing, we call this the silent killer sometimes, is it has a slower onset of action. So because the veins typically bleed slower, the symptoms may take hours, days, or even weeks to occur. So if that doesn't make you nervous after having a patient with a head injury, then I don't know what will. But signs and symptoms, the headache, of course, altered levels of consciousness, impairment in cognitive function or motor function, cranial nerve dysfunction. So what am I saying to you all? You're not out of the clear with a head injured patient, which is why it's so important to rest them for those 1 to 7 days to rule out an epidural/subdural hematoma. In this particular case, I think differential then would be, especially if they had some type of contracoup mechanism that they actually described to you overall. Next, we have a subarachnoid hemorrhage. That's what SAH stands for. So subarachnoid meaning below the arachnoid layer, but in between the pia mater and the arachnoid layer, right? It can be traumatic or spontaneous. So obviously traumatic means most often it's going to be some type of accident or fall. So a lot of force, right? Because it had to go through the scalp, through the skull, through the dura, right, through the arachnoid, and then live between the arachnoid and the pia mater. And we already know the brain is set up to kind of dissipate most of those forces. So it's going to take, on the traumatic side, it's going to take a lot of force to cause this, right? I guess what I'm saying to you is you can rest assured most of these do not occur in sport, but still you need to make sure that you at least have some type of understanding, right? Majority of the subarachnoid hemorrhages are going to be from bike or motorcycle, auto accidents, right? Lots of force. Hard part with subarachnoid hemorrhages that are traumatic and really spontaneous is that this is a really poor prognosis. In other words, the symptoms take so long to develop. Most often there's severe disability, a vegetative state, which is most often associated with other things that occurred in that particular accident. And so mainly death has been associated with a subarachnoid hemorrhage. Again, remember, I said this doesn't happen very often in athletics. On the spontaneous side, we were thinking like a hemorrhagic stroke. So the patient suffers from some type of atriovenous malformation or has some type of bleed that they are unaware of, but most are caused by some type of aneurysm. So some type of spontaneous aneurysm that the patient wasn't aware of. We do know that patients who have high blood pressure or who smoke tend to suffer from the spontaneous type of subarachnoid hemorrhage more than not. That pretty much has to do with like pressure on the arteriovenous system, but prognosis is not good in this instance as well. So 60 to 70% fatality rate within 30 days. But I guess traumatic, the prognosis is better than the spontaneous. All in all, as we think about subarachnoid hemorrhaging, one of the things that we have to consider is how is that patient going to present to us, right? So one of the things that we know about patients who suffer from a subarachnoid hemorrhage is their physio and neural exam may be normal, because remember, really it's an aneurysm that ruptures, right? So we have this ruptured blood vessel, and so it may take time for the patient to present itself in terms of the clinical setting, right? So one of the things that we want to look for is, okay, sudden severe headache or that thunderclap. They're going to say, I have the worst headache of my life. The nausea, vomiting, dizziness, increase. This is going to occur from increased intracranial pressure. They might complain of a stiff neck. We can also see that sometimes it's linked to low back pain because the meninges are going to be irritated. About 50% of patients experience loss of consciousness at the time of bleeding onset, and the other 50% don't, right? If the blood vessel ruptures, about 10 to 25% of those suffer from some sort of seizure. But things that have been different from the other two pathologies, photophobia, aphasia, and the fever is what they're going to present with, right? Okay, so in our physical exam, some of the things that we want to do, at least until we can actually get a patient to to a physician, we want to look at neurological findings, right? Loss of consciousness, confusion, and then focal neurological findings, the altered cranial nerves. Believe it or not, oculomotor palsy is most frequent, and so is abducens palsy, right? So just a quick kind of movement into a lateral direction to see if the eye is capable of doing that, then that's what we're going to do. And here's the thing that you have to understand. It's out of your control, because really the only way to treat that is with some type of pharmacological treatment. So oftentimes calcium channel blockers will work, or anti-hypertensive agents if they have high blood pressure, right? So it's out of your control. The only thing that you can do as a healthcare practitioner is identify it, right? That's a big key thing in many of these pathologies. Being able to identify it, being able to emergently respond, and then refer out so they can get the treatment that they actually need. So a pathology that may actually be present in the clinical setting of an athletic trainer is a skull fracture. The prevalence of skull fractures, I should say this, is much higher in athletes who are not wearing headgear than those who are. So our soccer athletes, for example, or if they're wearing improperly fitted headgear, the risk of skull fracture is relatively high. I wanted to say that, but then say skull fractures can also occur when the head is protected. The incidence rate of that is just higher in those that are not wearing some type of protective headgear and participate in contact sports. So when we think about skull fractures, there are different ways in which a skull can be fractured. It can be a linear, just a what is it called? A clean fracture. It can be comminuted. Remember that term, where it's broken up into little pieces, or it can be depressed. And so by depression, it means the skull indents inward toward the brain, kind of applying some type of pressure, right? But as we think about it from a subjective perspective, what's the patient going to tell us? Some type of blunt force trauma occurred to the skull. So there has to be some type of trauma, direct impact to the skull. The patient's going to be in extreme pain on the top of their skull because that's where the hit actually occurred. And many usually exhibit some type of sign and symptom of shock. They may, sorry for the typo, they may drift in and out of consciousness depending on whether or not they actually have a subsequent bleed associated with that actual skull fracture, right? In terms of objective, one of the things that you want to look for is a thing called a battle sign. So you want to look behind the ear, and you can see that in this image here. I'll blow it up really quick. You want to look for battle sign, which is pretty much like an ecchymosis that lives just posterior to the actual ear itself. So that's one thing that we want to look for. The other thing we want to look for is ecchymosis around the eye orbits, right? So that is independent of any blunt force trauma to the anterior aspect of the face. And then another clinical hallmark is going to be halo sign. So halo sign is where we have a skull fracture that has impacted the spinal cord. So you'll have cerebral spinal fluid coming out of the patient's ear. You'll put like a little, what am I thinking of? A gauze pad on the ear and kind of have them tilt their head if they're capable of that. If not, just place it on the ear and look for any drainage. Any drainage would indicate some type of spinal cord involvement. You may also palpate, particularly in a depressed skull fracture, you'll feel a defect. So what are we doing with these patients? We're stabilizing C-spine and we're calling 911. Main things you're going to do, maintain airway, and you may have to log roll if possible, if they're seizing or if vomiting occurs so that they don't choke. Again, what's the big key thing here for you all? Someone tell me. Good, to recognize that it has actually happened, to call 911, and to start your emergency action plan. If I haven't said that a whole bunch during this lecture, then I don't know what else to do. So I've talked a lot about activating EMS, but I truly do mean this with all of the acute head traumas that I've just discussed. The big thing that we need to do is we need to make sure that 911 has been activated, right? That someone has called. When do we call? If you have a headache that worsens, if a patient takes a blow to the head and immediately starts to seize, any weakness or numbness in the leg following a head injury, the list could go on. Slurred speech, unusual behavior, of course, after a head injury has occurred. Now, some of these you're like, Dr. Crosby, do I really need to call 911? The answer is to use your best judgment. If you're unsure and you've seen a blow to the head and you are concerned about your patient, then the recommendation is to refer that patient out by calling 911 and having them carted. It is better to be safe than to actually be sorry. That's the way that I think about head pathologies all of the time. Err on the side of being more conservative in your approach to treatment for patients who've suffered from a blow to the skull. One thing that EMTs and paramedics use oftentimes, and even physicians if they're in the clinical setting, to kind of assess the severity of the head injury is something called the Glasscock Coma Scale. You can see that here. A severe head injury, like a traumatic brain injury, is one in which this patient scores less than 8, right? And that could be relatively simple and easy. First of all, do they eye open at all, right? Or do they open to pain, speech, or spontaneous, right? That means they're healthy, happy, and very much alert. So you can see the lower scores represent a patient who is unresponsive, right? So you're going to add these 3, the eye response, the verbal response, and then motor response. You're going to add those 3 categories together. Patients with an MTBI typically have a score of between 13 and 15. If a moderate head injury, 9 to 12, and severe, you're definitely referring out if they score less than 8. So this is another clinical tool or clinical pearl to use as you're assessing the extent of the actual head injury and trying to decide if a call to 911 is warranted or not. And this is relatively easy, right? You're going to talk to the patient, tap and shout, "Are you okay? Are you okay?" Do they open their eyes? Can they talk at all? Are they confused? Are they oriented, right? And then last but definitely not least, what does their motor response look like? Do they have that kind of flexion posture, decorticate? Do they have that decerebral posture, right? Extended posture. You can see that extension postures are considered worse when compared to flexion posture. So just things to think about as you're assessing a patient with a traumatic brain injury. So I've mentioned a lot the cranial nerves. We have 12 of them. You all will have your own way to memorize them. Cranial nerves 1 through 12 always have to be assessed in a traumatic and really a mild traumatic brain injury. In terms of their function, you'll have to memorize those for the purpose of the exam, right? We can see their functions listed here. And then what's more important to me in this class is not only knowing their function, but also knowing how to test them, right? So the olfactory nerve, I typically would have either some type of perfume or a cup of like coffee beans, and I would have the patient smell. For this one, what we're looking for is, for the optic nerve, what we're looking for is kind of peripheral vision, which can be attacked most often with the H pattern. You can see H pattern for optic, oculomotor, trochlear, and then abducens. For your trigeminal nerve, it's really going to be like facial sensation. So you're going to touch the patient's face, the jaw area, and you're going to have them clench their teeth for motor. For facial, frown, smile, stick your tongue out at me. For vestibular cochlear, you're going to snap your fingers right near the patient's ear to see if they can hear, and then you're going to do the balance test. And then for glossopharyngeal, just say ah, right? For vagus, make them swallow. For accessory, shrug. And then hypoglossal, have them stick their tongue out. Now, if we really want to kind of assess the cranial nerves like holistically, we're going to do some eye assessment, right? So visual acuity, pearl, and tracking. That will get cranial nerve 2, 3. What is that? 4, right? And 6. And then in terms of balance, the Romberg test or the best test will work perfectly fine. Speaking to the patient speaking would get many of our nerves. Smiling, frowning, sticking out tongue would get these, so forth and so forth on, right? So we can see that we can do like a quick assessment of our patient if we don't have the time and we're sitting on the actual sideline trying to figure this all out. All that to say, I'm going to come back to the slide here. One of the things that I'm going to say to you is we're going to do these in lab. So hopefully you don't feel like I'm rushing through these, but this is memorization. Like you have to know that optic nerve or cranial nerve number 1 is the olfactory nerve, and that's smell. You have to know that cranial number 7 is facial nerve, and this is its function, and this is what it would do. And I can't help you memorize that. There are definitely things to learn, like to touch a fine velvet garment, vastly heaven, right? So that's the way that I kind of help remember it, but you have to come up with your own pattern. If you'd like extra credit, what I would do is come up with your own mnemonic for the cranial nerves to help remember that and bring that to class when I see you. Okay, moving back, just as a summary, you can test most of the cranial nerves. In a group, right? You don't have to do them independently, especially if you don't have the time on the sidelines. We talked a lot about the upper quarter screen in the cervical spine injury lecture, but I do think it's worth mentioning here that anytime we have compromise to the head, if we've ruled out traumatic brain injury, we still need to perform the upper quarter screen to figure out which nerve level might be impacted, right? And again, we're going to do these in class, but here are the dermatomes. So sensation, touch the deltoid, lateral forearm, thumb, index finger. C7 is going to be middle finger. C8 is going to be like pinky finger, and I would even say ring finger. And then T1 is going to be medial elbow. It's myotome, shoulder abduction, elbow flexion with wrist extension, elbow extension with wrist flexion, thumb opposition, finger abduction. And then awesome, fun reflexes that we'll get to do in class. But anytime we have a head injury, if a traumatic brain injury has been ruled out and we're not referring that patient right away, then we should do both a cranial nerve screening and then also an upper quarter screen if we have the time to do that. So if I could probably bring this home, one of the things that we have to be thinking about is the big picture, right? Traumatic brain injury, mild traumatic brain injury, repeated subconcussive blows, they all have long-term consequences for our patient, right? So I want us to start thinking about our patient as more than just an athlete and think about them as a mom or a dad or a significant other at some point in time. Because when we look at the big picture, patients who suffer from head injury oftentimes go on to develop long-term diseases. Some of those can be Parkinson's, dementia, Alzheimer's, ALS, and then the newest one is chronic traumatic encephalopathy, or CTE, right? In addition to that, several psychological disorders have been linked to patients who've had repeated subconcussive blows, and those include, number one, depression, the development of anxiety and personality disorders, and drug abuse. Oftentimes, to reduce the pain or the symptoms, they'll become addicted to some form of narcotic, for example. So let's talk big picture, because CTE has been a big topic over the last 5 years, especially as we've had athletes kind of commit suicide and then kind of commit their brain to research. But CTE is a chronic pathology that develops over time and presents very similar to Alzheimer's, has similar signs and symptoms. Patient will forget or lose their memory. They might suffer from depression, as an example, might have aberrant movement patterns. The hard part is it's linked to patients who suffer from repetitive head blows. So our boxers, our MMAers, our football athletes in particular, our running backs and our quarterbacks are going to be the ones that are going to suffer from that the most. And so what we see most often is the deposit of the tau protein, which normally supports the structure of the nerve cells. So we start to see more of that being developed over time. And so we start to see kind of this hardening of the nerves. The hard part is it's typically not present or typically can't be diagnosed until post-mortem. So let's look at a healthy brain, right? In a healthy brain, what we see and what we can see in this image is those nerve cells. You can see them there, and those cranial nerves, all of those nerves they're white and they're healthy. As we move to a CTE brain, we can start to see how red and thick they are, right, which it leads to kind of disruption. And then in Alzheimer's brain, we can kind of see how they become necrotic over time. But we can see the enlargement of these structures, and we can say that both of these pathologies are going to present very similarly. Difference with CTE is that most often it develops in a younger patient population, so that's one of the differentials. Ultimately, as I've said, when we work with athletes, we have to think of them as much more, because if we go back to this big picture slide where we're looking at the long-term consequences, it becomes important to really, truly just understand, number one, there is much more at stake than winning a championship, right? This patient may go on to develop chronic diseases or psychological disorders that would impact their family life. So keep that in mind as you work with patients who suffer from traumatic or mild traumatic brain injuries. All right, I'll finish the lecture by talking about, should we manage all concussions the same? You all are bright enough to know that the answer to that is absolutely not, right? Each concussion needs individualized, a customized approach based on the patient presentation, right? Return to play currently is highly subjective. It's going to be based on the individual patient, but then also it's going to be based on what you and your medical director have agreed to. So having a relationship with your medical director will be extremely important, right? There has the other part about diagnosing and kind of grading concussions is there really isn't a gold standard. So, and diagnostic tools as well. So it becomes important to use multiple assessment tools to help you with your return to play decision. So that could be like the SCAT-5, that could be VOMS and something else, right? The King-Dybbuck test. Typically, neuroimaging is typically unremarkable. So MR and CT scans typically are not useful in the initial diagnosis unless, of course, you expect a traumatic brain injury, which you're trying to rule out. So again, if you're suspecting traumatic brain injury, then MRI, CT are great. But if you're really dealing with an mild traumatic brain injury, they just are great diagnostic tools. One research study that has been published is actually looking at using saliva to determine the presence of concussion. So we may be to a place to where we can look at certain markers of a patient and to see whether or not they actually have a concussion. So that may be new, up and coming. But for now, biggest key thing is using your clinical tools to help you with your diagnosis. In terms of treatments, we always refer, especially when it's the first concussion, we're always referring out to a physician to let them make the call. Remember, we're athletic trainers. Like, our job isn't to actually diagnose the MTBI. We let the physicians do that, and then we come alongside our patients, and we do a couple of things. The first line of treatment is rest for that neurometabolic cascade. Remember, we want the body to physiologically and cognitively return back to normal. Medication is okay. So Tylenol is great for pain, but you're avoiding ibuprofen because it does, in some instances, cause a decline in, it thins the blood a little bit and may increase the risk of bleed. In terms of dietary restrictions, caffeine, spicy foods, alcohol, all contraindicated, okay? Alcohol, spicy foods, caffeine, all contraindicated. What we really want to do is hydrate that patient, especially because there's this energy crisis going on. So where you can, encourage the drinking of water. Okay, big thing is we have to look at the whole picture. Part of your job as an athletic trainer, I think this is the best job, is you know your athlete like no one else knows them unless it's mom, dad, or significant other. So what we want to do is we don't want to just focus on the signs and symptoms that they tell us, because the reality is they could be lying to us. We also want to do is use our clinical tools to help us make the decision, right? Now, I've said this before, but big thing is we want to establish and follow the return to play criteria. We do that with a physician. And we don't want to be varied in that, because that's when litigation and lawsuit kicks in. The big thing is no physical activity, until they're symptom free. Unless they're diagnosed with post-concussive syndrome, then there's a whole different set of standards and rules that apply to that. Initially, you want to limit strenuous cognitive activity, so maybe not returning them to class because of the neurometabolic cascade, and want to avoid any triggering events. And then, yes, every day they check in with us, unless it's Saturday and Sunday and we're actually off that day. Return to play criteria. Standard is minimum of 7 days symptom-free at rest and during activity. Activity cannot start unless the athlete has been symptom-free for 24 hours. There's some research to kind of refute that. In fact, there is an MSAT student who's working on a project now which says a little bit of aerobic activity does no harm and actually does good in terms of signs and symptoms. But progression, what does that look like? So get on a bike, no symptoms. Light jog, no symptoms. Heavy cardio, plyometrics, weights, no symptoms. Non-contact practice, no symptoms. Limited contact practice, no symptoms. Full contact practice, no symptoms. Return to activity. Let's go. Now, there are some states that have specific concussion laws in place. And so in that instance, you want to follow those, or you could be held liable. Post-concussive syndrome, symptoms lasting longer than 2 weeks most often. But again, it could very well last longer than that. Preliminary research suggests that concussions can be defined into 3 categories: physiologic, vestibulo-ocular, cervicogenic. So I'm going to skip the slide and go here. When we think about a physiologic concussion, what we're thinking about is we have patients who've had some type of alterations in neuronal depolarization. So these are the patients most often that are going to be in that kind of energy crisis. They've had a disruption to the cerebral blood flow. So they are the traditional MTBI that I've defined. The 2 that are probably, what's the right word? I guess more uncommon are the vestibular ocular, which means they have disruption or dysfunction directly to the vestibular oculomotor system. So they're going to have, their symptoms are going to vary. They're going to be different. Dizziness, vertigo, nausea, lightheadedness, all of those things, balance issues for the most part, is going to be that patient. And then you have cervicogenic, which is linked to muscle trauma of the neck mostly, and dysfunction of the cervical spine. And so then these patients are going to report with more of the muscular signs and symptoms. So again, we're taking a holistic approach. We're saying, okay, well, what's good for the patient that's sitting in front of us, right? If they are physiologic and they actually are having neurometabolic signs and symptoms, then we want to rest them. We want to get them school accommodations, right? If they are vestibulo-ocular, then we're going to do a lot of things that are geared towards restoring proprioception and balance. And then here, we're going to do a lot of manual therapy with that particular patient. Last but not least is the youth athlete. We've talked about differences between the youth athlete and the adult athlete. We know that younger athletes are at greater risk just because their brain is immature. Their maybe the density of their bone hasn't completely formed yet. And so because of this, one of the other things that we know is they may not be aware of their symptoms. They're just fully growing into who they are. And so we're going to use those graded symptoms checklists like a SCAT-5. We're going to use VOMS. And their developing brain just takes longer to heal. So their brain may take longer, or their symptoms may take longer to reside themselves. The big concern with a youth population, like I said before, is the risk of secondary impact syndrome. Just because we're going to return them to play sooner, they're younger, that's what we think. So we want a slower, more gradual return to play if possible for this particular group of athletes. All right, that concludes the online lecture for traumatic acute injuries. I hope this has been helpful and you've learned a lot along the way. Looking forward to seeing you in class and in lab.